Welcome, everybody, to this edition of Weekly HCC Chart Review, brought to you by American Association of Medical Coding Professionals. Today, we are going to talk about neoplasm, and this is actually going to be a topic we will do several times more in the future, just because it is voluminous. I mean, there's just no way to cover everything that needs to be covered, in the space of an hour. Um, and hopefully, some of you may be new to chart review. And, I think once you get comfortable, maybe, and hopefully you're comfortable right now. Hopefully you'll be able to ask questions and participate now. But, what we find is some people, take a little time to get into the groove. And so one of the things about chart review is, we want to hear what your challenges are, where your blind spots are. We want to help you overcome them. So, this should be very interactive, and this should be, focused on what your needs are, not just what the topic we pick, and so please feel free to make suggestions, to ask questions, whether it's here in this session or between weekly chart reviews. If there's something that's gnawing at you, please let us know. We will do all we can to help you out. So neoplasms, reviewing and coding an oncology record can be daunting because there's a lot of unfamiliar terminologies. First of all, there's a lot of complex terminologies. There's a lot of there's a wide range of terminologies, and we'll highlight this when we look at the number of ICD-10 codes that map in the neoplasm category. And treatment options. The treatment options are quite unique to this disease group. So, to accurately assign ICD-10 codes for neoplasms, we should possess a knowledge of neoplasm-related terminologies, and we're going to cover that after we look at some charts. And a good understanding of the neoplasm disease process, common treatments. And in coding neoplasms, specificity and documentation is a key factor, as well as determination payments for risk adjustment. And we're going to look at that here in a moment as well. That's kind of where we started today. Like I said, we're going to do as many sessions on neoplasms as necessary, but certainly can't cover it all in one session. It's just too much. So, we're going to use today as a starting point, and hopefully we'll build on that, not only in what we have planned, but in response to, your needs, your questions, etc. So let's just take a look at some common terms that you're going to see in documentation. Okay. And some of these will help you with your productivity. In other words, if you understand, I mean, there's very few benign or non-malignant tumors, et cetera, that risk adjust. So, on the left, we have these non-cancerous benign, terms that you can use to save yourself time from drilling down on something that is not going to be fruitful from a risk adjustment perspective. So, adenomas, fibromas, hemangiomas, lipomas. Lipoma is just a fatty cyst. Okay. If it becomes malignant, it's going to be called something else, right? So, hyperplasia, atypia, metaplasia, dysplasia. So, dysplasia is something you're going to see a lot, okay? And that can go either way, depending on how the provider uses that term. Dysplasia is just it just didn't grow normally, or there's some abnormal growth, but it doesn't necessarily it doesn't necessarily key into malignancy. Now, dysplasia can certainly become malignant, okay? But so dysplasia is something you're going to want to, to take a little closer look at if you see it, okay? There are some terms that when you see them, you are going to instantly know that there's a malignancy, and you should be, proceeding with your coding process. Carcinoma, leukemia, lymphoma, sarcoma, multiple myeloma, melanoma, cancer of the CNS, central nervous system. So, and this is not a all-inclusive or complete list. So the purpose of this slide is to key you into bolstering and refining, polishing your neoplasm terminology, okay, and being as familiar with that. When you're coding records, you don't want to you have a productivity standard. You don't want to let your productivity be sacrificed for learning on the fly. You know what I mean? So the more you have under your belt in knowledge, the less time you're going to take from your productivity time. Okay. So we are undergoing a massive change. Okay. And it began back in April. Okay. We are moving from the V24 model to the V28 model. Okay. And so I just want to take a moment to highlight some differences here. Okay. In the V24 model, we had 5 HCCs in the hierarchy of neoplasm. Okay. They were HCC 8, 9, 10, 11, and 12. Okay. And HCC 8, metastatic cancer and acute leukemia, had 82 codes. HCC 9, lung and other severe cancers, had 110 codes. HCC 10, lymphoma and other cancers, had 534 codes. HCC 11, colorectal, bladder, and other cancers, 133 codes. And HCC 12, breast, prostate, and other cancers and tumors, 269 codes. Now, we are in what's called a blended model. Okay, so while V28 is being phased in and V24 is being phased out, you will still capture all the codes from V24, but you will also be capturing any new codes that are introduced in V28. And so if you are on chart review here, then you probably have access to the desk reference. If you don't, let us know, and we'll get you access to that. But the desk reference has all of the changes, and so at this point during the blended model, what you want to really be sure of is you're coding any new codes that did not map in V24. Okay, but this is V24. And so let's take a look at V28 real quick. And so in V28, there are 7 HCCs. Okay, so we went from 5 HCCs to 7 HCCs. And the numbering is different, with the exception of the first 3 HCCs, starting with neoplasms and the rest of the HCC hierarchy tiers. All the HCC numbers have changed. Okay, 17, 18, and 19 in V24 are diabetes. Okay, 17, 18, 19, of course, 20, 21, 22, 23 in V28 are cancer HCCs. So just in case you need to know that. So HCC 17, and you'll see that the titles of the HCCs in this case have changed, okay? Which is not, across the board, that's not always the case. There's a couple hierarchies where the titles stayed the same, but certainly the HCC numbers changed, and new codes were introduced, other codes were deleted, et cetera. So So HCC17, cancer metastatic to lung, liver, brain, and other organs, acute myeloid leukemia except promyelocytic, 75 HCCs. Cancer metastatic to bone, other and unspecified metastatic cancer, acute leukemia except myeloid has 26 codes. Myelodysplastic syndromes, multiple myeloma, and other cancers has 63 codes. Lung and other severe cancers has 219 codes. Lymphoma and other cancers has 434 codes. Bladder, colorectal, and other cancers, 126 codes, and prostate, breast, and other cancer tumors have 23 codes. Okay, so so let's just back up one. There were 1128 codes, 1,128 codes in V24. Okay, there's about, what is that? About 47, a little less than 50 more codes in the V28 model. Okay. Now, when I say a little less than 50, there were some that were removed and then there were some that were introduced. So it's not just 50 new codes. It's a net increase of a little less than 50. But check with your desk reference in the system. In the system, the desk reference is, you can download it as the full desk reference, but we've also put each HCC category hierarchy. Okay, so Neoplasm, there's 7 HCCs in it, but we put the Neoplasm in there so you can reference a disease group by disease group by disease group. So we try to make it as universally user-friendly as possible. So 1,175 now codes in 7 HCCs. Okay, and so depending on your role, depending on the organization you're in, you may need to pay attention. Some risk adjustment coders never even know what HCC category they are dealing with, because they're putting a diagnosis into a system and it says yes, it maps, or no, it doesn't. And but as a professional, you should certainly understand what you're doing, even if it's not something you manually have to do. But so these are the two categories. Okay, V24 and V28, 5 HCCs, 7 HCCs, net difference of a little less than 50 codes, but it's not simply a 1-for-1 trade-off on 50 codes. Okay, so we really like to kind of reverse engineer or work backwards from errors to how do we get to errors. Okay, and of course the gold standard for determining errors and what is a common error and what isn't, etc., are RADV audits. Okay, and is there anybody, can I see in chat, yes or no? Is there anybody who doesn't know what RADV is or stands for? Anybody? Okay, I see. Me. So that means you do not know what RADV stands for? And don't be shy. Don't be okay. So good. So this is going to be this is something. And are you an HCC coder? Do you code HCCs? Oh, okay. And by the way, if you'd like to speak, you may. I have everybody muted, but if you'd like to speak, you may. You just say unmute me. Just type unmute me. But what environment do you code in? Okay. You're doing the Profi. Okay. And so this is very important. Okay. Because and hopefully you said you're taking the full course, and that's great. Um there's everything starts at the encounter level. Okay. And so everything comes from the documentation that the provider records from an encounter, and the way that the information is submitted to CMS is primarily now through claims data. So you submit a claim to your payer, and they turn around and they send that claims data to CMS to calculate risk scores. So coders, pro fee coders, whether they know it or not, and you are adding to your marketability and your resume and your value as a coder. So many pro fee coders don't recognize, they don't know anything about HCCs, they don't know anything about anything, but they're a critical link in the chain. Okay, and so the diagnoses that you're submitting, coding and submitting on your claims are going to end up in these RADV reports if they're incorrect. So back to my question, I asked if anybody didn't know what RADV is. Sure. It stands for Risk Adjustment Data Validation. Okay, and so there is a boatload of money at stake here in risk adjustment, where CMS pays these health plans a premium to cover Medicare beneficiaries. Okay, and so the patient is no longer on Part A and Part B. CMS and the federal government is no longer paying each individual claim. These major carriers like United Health, Humana, everybody, they are now paying the claims for these members. Okay, and so the government pays a premium each month to cover the beneficiary, and that premium amount is increased for certain conditions, which are HCCs. Okay, so because the government is paying all this money, they are doing, they are auditing to make sure that they're being assessed correctly and paid, not overpaying. And so this is a RADV cover report on the left. And so, like I said, we like to reverse engineer. Okay. And so you can see this medical records does not support submitted diagnosis codes or any other diagnosis codes. Okay, which is that's not a good heading. Okay. For example, for enrollee A, Humana submitted a diagnosis code for malignant neoplasm of the larynx, which maps to both version 12 model HCC for lymphatic, head, neck, brain, and other major cancers, and version 22 model of HCC for colorectal, bladder, and other cancers. Now, as of the time of this, you see the version, and we just talked about versions. We're actually moving from V24 to V28. V22 was only in play for a little bit, okay? But the Medicare Advantage program has been in place for 20 years, okay? And there have been revisions and updates, et cetera, et cetera. So major updates are moving from version to version. And so we're moving from version V24 to V28. So just, and RADV audits are often years after the encounter, just for a number of different reasons. Okay. And I'm not going to spend all the time to explain that here. But so here, this maps to both version 12 and version 22. Okay. However, that diagnosis was not supported in the submitted medical records. And that statement right there is why we do chart review. Okay. So that people can understand the end result of their coding. Okay. And see the, end to end how their coding today can end up being identified as an error later down the road. Okay. So that diagnosis was not supported in the medical records. Our independent medical review contractor stated that Although these diagnoses were listed, there is no documentation that indicates that they were monitored, evaluated, or treated. Okay, and that is three-quarters of the term meet: monitored, evaluated, assessed, or addressed, or treated. Okay, and the documentation clearly indicates that the diagnosis had been previously treated and was noted as resolved. Additionally, there are no other diagnoses in the medical records that, submitted that would result in this HCC. So, right there, that sentence right there indicates the biggest error in the neoplasm category. Okay. And that is current versus historical. Okay. And a historical condition that no longer is active does not qualify for an HCC, and there's no other category where the provider using this term history of, or not using the term history of, has as prolific an impact as it does here in the neoplasm category. Okay. So again, let's read that again. The documentation clearly indicates that the diagnosis had been previously treated and was noted as resolved. Additionally, there are no other diagnoses in the medical records that would result in this HCC. Okay. So, and we're going to look at, this is going to be involved in one of our charts coming up here. Okay. So, a patient who has a particular cancer, if they have been treated and are in remission, and I really don't like using the word cured when it comes to cancer, just because I just don't believe that is a term that could ever be used with 100% confidence. But if the cancer is no longer active, then it will not qualify for an HCC. Okay. If a patient had colon cancer 15 years ago, and the colon cancer, I don't know if they had a resection, whatever, but now they are quote unquote healthy, they don't have any active colon cancer, it does not map to an HCC, okay, because they're not actively being treated for colon cancer. That phase has passed in their life. They are essentially clinically the same as somebody who doesn't have colon cancer. Okay, so that's where this currency of a condition really comes into play. So documentation clearly indicates that the diagnosis had been previously treated and was noted as resolved. So this is one of the big errors in the neoplasm category, where the documentation shows one thing, but the coding shows another, and it results in overpayments. Okay, so this is a particular, just one beneficiary, right? So, as shown in Figure 1, the diagnosis codes that Humana submitted to CMS on behalf of enrollee A submitted to 15, mapped to 15 HCCs. CMS used this to calculate a $3,371 monthly payment made to Humana. Because of the HCC for lymphatic, head, neck, brain, and other major cancers, and the HCC for colorectal, bladder, and other cancers were not validated, the CMS payment should have been based on 13 HCCs, which would have resulted in a monthly payment of $3,006. Okay, so look at those numbers, first of all, folks. If you have health insurance, and especially if you are in tune to what you're paying, i.e., you've bought a plan from an individual plan as opposed to a group health insurance plan, but even if you're on an employer's group health plan, you know what your contribution is per paycheck, per month, per year, whatever. Okay. So $3,371 per month. Okay. So that means that CMS is paying $36,000 a year to Humana to cover this beneficiary. $36,000 a year. Okay. This particular error, you can see this error caused a $4,380 overpayment for the year. So if they're paying $36,000, they should have been paying $32,000. And you can say, yeah, what's the difference? Well, it's not your. If it was coming out of your pocket, you would certainly be in tune to the difference. So this is just one example of the impact of how coding and in today's topic is neoplasm, how this can impact. Now we're going to take another look at. So we looked at an overpayment, okay, but now out of fairness, the reason that these health plans get more for an HCC is statistically and in reality, these beneficiaries are more costly to cover for a condition that maps to an HCC. Okay. So let's look at this. For 2 of the 20 submitted HCCs, Humana did not submit diagnosis codes that map to the most severe manifestation of the HCCs in these related disease groups. Instead, Humana submitted only the diagnosis codes that map to the less severe manifestations. If Humana had submitted the correct diagnosis codes, the more severe HCCs would have been used instead of the less severe HCCs. These errors led to underpayments. Okay. If you work in a store and an item costs $50 and you are, ringing it up wrong, and every customer that comes in and buys that item, you're only charging them $25 instead of $50. Your employer's not going to be too happy with you, right? You are costing them money. Okay. Well, as an HCC coder, that's exactly what happens if you undercode. Okay, so if you overcode or code something wrong, now the health plan is getting money that they shouldn't be getting, and that is certainly a compliance risk. Okay, and undercoding is as much a compliance issue as overcoding is, just so you know. Okay, but in this case, you are costing the health plan money. Okay, not you. The coding in this scenario costs the health plan money that they are due. Okay, so the government doesn't want to overpay, but the health plan doesn't want to be underpaid. Okay, so everything should be proper, right? So for this sampled enrollee, Humana submitted a diagnosis for multiple myeloma without mention of having achieved remission. The diagnosis code maps to both version 12 model HCC for lymphatic, head, and neck, brain, and other major cancers, and version 22 model for lung, severe, and other cancers, both of which are less severe manifestations of the HCCs in these related disease groups. However, our independent medical review contractor found support in the submitted medical records for the diagnosis secondary malignant neoplasm of bone and marrow, which maps to the HCCs that were both more severe manifestations of the HCCs in these related disease groups. According to enrollee C's risk score, and accordingly, enrollee C's risk score should have been based on the HCCs with the more severe manifestation instead of HCCs with the less severe manifestation. As figure 3 shows, this error caused a $13,212 underpayment for the year. Okay. So I don't know. Think about your annual salary. If your company underpays you by $13,000 this year, you're probably going to be a little upset, right? So, as a risk adjustment coder, okay, and the person who said that they are a profi coder, whether you know it or not, you are an HCC coder. If you are coding records and they have anything to do with a person who is on a risk adjusted payer, okay, and you shouldn't have to think about or look up whether you're coding for for that person. If you understand the correct coding process, you should be coding every record regardless the right way, and then everything will take care of itself. But again, $13,000, okay? is there anybody here today who is willing to just eat $13,000 for somebody else's mistake? Probably not. Okay. So the coding, not just neoplasms across the board, if it's complete and accurate, everything will be fine. Okay. When it's not complete and accurate, you can see that has very significant impact. One other thing in the essential tools and resources, okay, because you see our independent medical review contractor, there is a document in the essential resources that is the document given to these auditors who do the RADV audits that is very useful, okay, that has common scenarios and CMS's instructions to the auditors on how to handle those common scenarios. Okay, so just something to something to be aware of, stick your nose in and understand. Okay, so let's take a look at a couple charts. Okay, and just let me get over to it. Okay, so the first one I'm going to take a look at here is, oh, I can't get my, there we go. So let's take a look at this this chart. Aaron C. Rescue. Date of birth, April 9th, 1983. It's a male. Date of visit, 7/12/23. Primary care physician is al dente. And so, history of present illness. A patient presents today for an oncology follow-up to address the ongoing management of the malignant neoplasm of the ribs and malignant neoplasm of the liver. The patient is experiencing anti-neoplastic chemotherapy-induced pancytopenia. Okay. The patient reports general fatigue, weakness, and occasional shortness of breath. No pain, no changes in pain or symptoms since the last visit. Physical exam. Patient appears fatigued, no acute distress. Vital signs are blank. Chest and liver examination of the chest area reveals tenderness over the affected rib area. Abdominal examination shows no palpable masses or tenderness. Hematologic blood tests indicate pancytopenia with decreased red blood cell count and white blood cell count and platelet count. Okay. So the assessment: malignant neoplasm of the ribs, malignant neoplasm of the liver, anti-neoplastic chemotherapy-induced pancytopenia, and the plan here. And we have the we have the attending physician, Al K. Seltzer. Okay. So anything jump out to anybody here on how we would code this? Yes, no, maybe. And as I mentioned to the previous person, I have everybody muted just because when we do these, if we leave people unmuted, then there's always dogs barking, doors slamming, babies crying, sirens wailing, this, that, the other thing. So if you'd like to speak, all you have to do is say, please unmute me or unmute. So Michael, primary versus secondary. Okay, that is exactly, that is one thing that is not determinable here, right? Is there metastasis? Are they two separately existing cancers? Is one a metastasis from the other? Okay, so this does not give us really quite as much information as we need. Okay, so what happens when you hit a wall like this? When something happens like this where there's not enough information, what do you do? So somebody said code them independently. And so the person and the other and somebody else said query. Okay. Now, the person who said query, are you an HCC? So I am gonna make it so anybody can unmute. Uh, you are now able to unmute yourselves. So the person who said query, if you'd like to speak, you may.
Yeah, that was my initial comment. And then the other thing that was going through my head, I know there's some cancers that are automatically secondary. I don't have that list in front of me. Can you speak about that?
Well, what I can say is obviously you have read your guidelines. Okay, and that is one of the points that I'm getting to. May I say your name? I don't like to out people. Can I use your name?
Yes, sir.
Okay.
Definitely.
Michael. So Michael, that one of the current themes that we will touch on in every single chart review we do is, and I'm going to be touching on it here before we close today, is obviously you've read your guidelines and the chapter specific guidelines. So the guidelines tell us what to do. Okay, and so if you run into a situation that is uncharted territory, bonus points if you get this, Michael. What happens if you run into something that you've gone through the tabular instructions, you've gone to the chapter specific instructions, you've done everything you can in the ICD-10 manual, and you still have a question? What's your next step?
I would search that condition in coding clinic. That's my first thought.
So you said the word I was looking for, but if you run into a situation where you can't find an answer, then you submit a question. That's what coding clinic is. It's an ongoing response to questions that have not been or not clearly dictated or addressed in the guidelines. So very good, Michael. Are you an HCC coder?
Yes, sir.
How long have you been doing it?
2006.
Yeah,
I missed a couple of years, but yeah, 10, 12 years.
It's pretty evident. I mean, you are, you're you are, and you speak with confidence. It's not like, oh, I think I would. You're very clear on your process. So kudos to you. Okay. So actually, now I think you had asked a question that I might have lost track of. No. So the person who said code them independently. Okay. Let me ask you this, and you can speak if you wish, or you can just type your answer.
Sure. I'll speak.
Hey, hi. So I mean, was that did that come from between your ears, or do you have some reference citation that says this is what I do?
That came from between my ears off the cuff.
Okay, yeah, and that's fine. Now you really want to stay away from that. And meaning, and the road to hell is paved with good intentions, right? So, just like Michael's been doing this for 17 years, I think, if my math is right. Yeah, 17 years, and probably in the beginning he might have gotten whacked on a QA or something, and he learned, okay, I'm not gonna operate independently. I'm gonna know the steps to getting to the right answer. And so with this, malignant neoplasm in the ribs, malignant neoplasm in the liver, okay, and Michael had said query. Okay, now Michael, what is the biggest problem as far as queries go in risk adjustment?
We're not going to have access to the provider.
Right. You're sitting there, most of us work remotely, and you're sitting, what part of the country are you in, Michael? Are you in the Northeast?
Chicago.
Midwest. Okay. So Michael's sitting there in the Windy City coding these charts, and he's got a record from a doctor in Albuquerque, New Mexico, from a data service of last August, right? Michael does not, this is not, he's sitting in an office in the same practice as the physician, and he goes over and says, hey, doc, this, or there's a electronic query system. And that's not the way risk adjustment is. Not necessarily real-time coding the way many other codings are. So yeah, so you don't have, often you don't have, and there are instances where you do have the ability to query, but it is actually kind of rare. It's not the norm in risk adjustment coding that you have now. Code them independently. Can I use your first name?
Yes, there's just two of us on the call, and we work together.
Oh, okay. There were more. Somebody must have dropped off. So Jennifer, okay. Now I forgot what I was going to say. Let's see. If you're a profi coder, no, wait a second. Didn't you say that you are a profi coder? You're not an HCC coder?
No, I am not a profi coder. She dropped off.
No. Okay, that was no. It was somebody else that was one of the people who dropped off. Okay, sorry, I had you. Sorry, I had you confused with somebody else who had. So there was somebody else, and I think they've dropped off. But that person who said they were a profi coder, okay. If they're a profi coder, they probably have the ability to query their physician, right? I don't know. I've worked in many practices. I worked for, I did coding for a cardiothoracic surgery group of 3 heart surgeons, right? I did coding for a 15 surgeon orthopedic group. I've done many different, I've worked in many practices. So if I had an issue, any kind of documentation or coding issue, I was able to resolve it because I worked within the practice. Okay. So as you guys know, when you're doing risk adjustment HCC coding, you don't always have that luxury. So yes, that would be, what do you do here? We got malignant neoplasm of the ribs, not identified as primary or secondary. Or no, we don't have any indication of metastasis or anything like that. So yes, we would, if we have the ability to submit a query, that's what we want to do, right? Okay. But now the handcuffs are on you because you don't have the ability to submit a query, right? And so what would be, so you're sitting here and you're working with this chart and you don't have the ability to submit a query. What is your, you're sitting here, you look, you've never seen this chart before today, right? This is just like something that showed up in your queue. If you can't query the provider, what steps are you going to take? You may not get to the answer, but what would be your next step? You say to yourself, well, if I could, I'd query the provider. I can't query the provider. Now what are you going to do?
Well, there was meat there to support malignant neoplasm of the ribs, malignant neoplasm of the liver, neoplastic chemotherapy-induced pancytopenia.
Okay, wait. There's and I think it's because I didn't ask my question as clearly because we all know what's there. We can all see what's there. So you see malignant neoplasm of the ribs. You see malignant neoplasm of the liver. You don't. The question mark has gone up in your head. Is it primary or secondary? Is there metastasis? Okay, and you can't ask that question mark. You can't take that to the provider. You can't query the provider. What would you do? What would your next step be? Just you're looking at this and you're saying, I don't have primary, secondary, metastasis, indication of metastasis, whatever. What would your next step be in your code assignment process?
I would code the malignant neoplasm of the liver.
Okay, so why would you do that? Well, I mean, it's not that I'm trying to be. I think it's the way I'm asking the question, and I'm trying to do it as artfully as I can. So this is what I would do. I would say, okay, I'm a coder. The coding has been going on for a long time. Okay, there should be a guideline for this, right? So I would see if there's precedent, okay, that guides me on, on what to do. You got two different codes. You don't know which is primary or secondary. This is almost like an inpatient determining what the principal diagnosis is. You know what I mean? So
Okay,
so I
so
would. I'm sorry. Go
let's
ahead.
go to the guidelines.
Huh? And we will, okay, just because I have to flip back and forth from presentation to PDFs, so we will. The other thing, since both of you are currently, and Jennifer, do you have anywhere near the longevity and HCC coding that Michael does?
Yes, I do.
Okay. Have either of you ever coded anti-neoplastic chemotherapy induced pancytopenia?
No, I have not.
No? Michael?
I've never coded oncology coding.
Okay. So
have you, Michael?
My coding started probably in 2006, went to 2010, where I was in the charts day to day. Other than that, we kind of move on from different roles. So not currently. I probably coded chemotherapy many a times, pancytopenia, not pronouncing that right, before. The only other thing that I could comment on, what was the admission? I know that doesn't change what we're looking for, but I'm neglecting their deferring. If they came in for that, for the, I know there's a guideline regarding the admission for like cancer-related issue, I believe. So I know there's some sequencing there, but no, it's been a while.
Okay, and so I was asking specifically about anti-neoplastic chemotherapy-induced pancytopenia, and I threw this in here for a particular reason. And the longer you've been doing this, the more important it is to understand. Okay, Jennifer and Michael, you've been doing this a long time. You didn't just get your risk adjustment coder certification 6 months ago, and you're learning the ropes. We've built habits. I've been involved in risk adjustment since day one, right? So just a couple of years longer than you. But this particular code has mapped, and it's going away in V28. So that's why I threw it in here. Okay. Because if you're still coding records, Mike, are you in some kind of supervisory role at all? It almost sounds like.
No, we're in education.
Yeah. Okay.
So so I'm focused on HHS risk adjustment now, version V07, but we are heavily involved in CMS as well.
Okay. So for the CMS HCCs, this has historically risk adjusted, but it's going away. Okay.
Got it.
So back to this one. So we've got two established malignant neoplasms. We have some missing information. Okay. And so step one is go to the guidelines, go to the chapter specific guidelines. And it sounds like both of you are very familiar with chapter specific guidelines. It's kind of amazing how many coders with a certification, you ask them about chapter specific guidelines and you get that blank stare. So this is one. I want to get to the other chart here, and then we'll go back and as Jennifer, we are going to go back and look at the guidelines. Okay, but let's see. I want to make sure I had these in order. Yeah. Okay. So let's look at this record here, okay? This is for patient Antique. Date of birth, female. History of present illness. Patient presents today for routine follow-up to address several ongoing health conditions. Patient has a history of hypertension, anxiety, osteoporosis. Additionally, she underwent a mastectomy in 2015 and successfully completed a 5-year Arimidex treatment, currently NED. Past medical history, hypertension, yada, yada, yada. Medications, Fosamax, Lexapro, Coreg. We got our vitals, etc. Okay. And we have assessment, hypertension, stable, anxiety, continues to manage anxiety, osteoporosis, continue monitoring, routine follow-up after successful mastectomy and completion of 5-year Arimidex treatment, currently NED. Okay. So since we got two veteran HCC coders here. What could you say about, as far as neoplasms? What does this record show?
It doesn't show the site, but the laterality of the mastectomy.
Is that important for this record?
Not necessarily. It shows a
Why?
history of cancer.
Right. That's what I was looking at. Yeah.
She completed her cycle of, her aromatase inhibitor. So it definitely shows a history of
history
cancer.
of, right?
Correct.
And we're going to be doing some others, as I said, we're going to be doing neoplasms, many, I don't know, I shouldn't say many. We're going to be doing more sessions on neoplasms. And I didn't want to, I really didn't want to start with that history of thing, just because I would have beat it to death. But, we're going to look at some records that have a little more murky wording, where providers love to use the term history of, and they use it. They're not trying to do anything wrong, but they use it in a different context.
Absolutely.
But from a coding perspective, history of means, well, it no longer exists. So we have that conflict. Okay, this one is more straightforward. Okay, had a mastectomy, completed treatment. This is a historical condition. And then we have NED, no evidence of disease, right? So this one's pretty straightforward, but I'm sure both of you will agree that you'll see records where it says history of, and patient is undergoing arimidex, right? So it'll say history of, but it'll certainly indicate that there is ongoing treatment or ongoing disease, and so we will be looking at those, but here's I have the same chart, just a little bit differently formatted. So this is all the same. Okay. And then we get down here. Okay. And we have, now here we have Z8583, history of, right? But how many times have you seen a provider, okay, and in the last two sessions, both we did stroke and we did major depression. I'm sorry, not major depression. My statement doesn't apply that, but in the cardiovascular, cerebrovascular CVA episode session that we did, same thing, where history versus the acute code. And we highlighted when it comes to a CVA, an outpatient record is just that the acute stroke code would never be appropriate. That's not where it's diagnosed and treated. It's diagnosed and treated on an inpatient basis only. You know what I mean? So, but here's the thing: is in this record, we could just as easily see breast cancer with the acute code, because the doctor picks it off the pick list and they don't understand coding guidelines, so this is the same record. But when we get into providers assigning codes, it becomes very precarious. And you guys probably understand that and have seen that, right?
Yes.
Yeah. So let's get back to the presentation here. And so I did include some of the, and for you guys, I don't know, have you guys delved into the changes, the V24 to V28? Have you guys started to assimilate, and educate yourselves on that yet?
Yes.
Okay. So here we have, the ICD-10 code, the descriptor, V24, V28, and the columns are a little, there was no way for me to do this, but if you, 8 is V24, 17 is V28, yes, and yes are does it map? Okay. So we have secondary malignant neoplasm of the liver, or other specified carcinomas of the liver, maps to HCC 20, right? But if we go over here, we have malignant neoplasm of the long bones, or ribs, etc. That's going to map to HCC 21. Okay, And so you know, I put this in here to kind of tie back to that RAD-V report that we looked at, where, you know, coding error number one costs the government money. Coding error number two costs the health plan money. Okay. And so the moral of the story is we got to get it right, you know, not just good enough. So one of the things that I want to stress for, obviously for people who might be watching this on demand, because our remaining folks on this session, Michael and Jennifer have both have this, you know, this is woven into their fabric. But if you don't know, if you don't know about your chapter specific instructions in the official guidelines of coding and reporting, you need to educate yourself, because you know, and Michael and Jennifer can probably you know, back me up on this. When you're in the tabular list, there's no little note that says, oh, go to the chapter specific instructions. No, you got to know, you've got to know that they exist. You've got to know, you know, have an idea of what the guidance in them contains. You don't have to remember word for word, but you should understand that you need to understand that they exist, and you should understand, you should know when you need to refer to them to get the very specific guidance that's contained in them, right? So Michael and Jennifer, right, you'd agree that, you know, when you're sitting in the tabular list looking, there's no little emoji that says go to the chapter specific instructions, right? I mean, you've got to kind of know that they exist. You got to kind of know what is contained in them to be able to use them effectively. Would you agree?
Absolutely.
Okay.
Definitely.
So, and you can see for Neoplasm, look, there's one or two chapters that have, you know, no chapter specific instructions, but most of them do. And Neoplasm has, you know, a fair amount. So this is from the table of contents for, you know, for the official guidelines of coding and reporting, chapter specific instructions. And you can see there's ample instructions here. So, general guidelines, chapter 2 of the ICD-10 contains codes for most benign and all malignant neoplasms. Certain benign neoplasms, such as prostatic adenomas, may be found in the specific body system chapters. To properly code a neoplasm, it is necessary to determine from the record if the neoplasm is benign, in situ, malignant, or of uncertain histologic behavior. If malignant, any secondary metastatic sites should be determined. So, and that last part is, you know, we hit a wall with that, right? We didn't know whether the liver and the rib were primary, secondary, which one was which, or if they were independent of each other, right? So, here is, you know, some guidance. Malignancy in 2 or more non-contiguous sites. A patient may have more than one malignant tumor in the same organ. These tumors may represent different primaries or metastatic disease, depending on the site. Should the document be unclear, the provider should be queried as to the status of each tumor so the correct codes can be assigned. Okay. And I think Michael introduced this notion way back when I first asked a question, sequencing of neoplasm codes. Encounter for treatment of primary malignancy, encounter for treatment of secondary malignancy. Now, here's the thing, okay? And I think Michael and Jennifer would probably agree that, you know, when you're working in a record, you have the potential for hitting some obstacle, okay? And I would say 95 to 98% of the time, the guidelines, you know, we've been coding for a very, very, very long time. So there's usually precedent, okay? And so usually you'll be able to find an answer, a solution, etc. Gotcha, Michael. Thank you. You usually be able to find an answer in your guidelines that will direct you to an end result. But and Michael had to go, but Jennifer, maybe you could chime in here. But occasionally you follow your process, and there is no way for you to to competently or proficiently code that record without a query or without an answer from a physician, et cetera. Correct?
Yes, absolutely.
Yeah. So I think there's one of the problems is some coders feel like I've got to come to some resolution. Okay. And they will end up assigning a code so that they can say they assigned a code. You don't have to if you cannot reach that code and touch it, then don't. And in risk adjustment, your organization should have some mechanism for reporting, couldn't code this, they call it flagging, a missed opportunity, et cetera, et cetera. So don't resist that temptation of well, I've got to come up with something. Okay, that is not the answer. Okay. We're coming up on an hour. I'm going to run through some of the rest of the presentation, and the PDF will be in the system. Most of the remainder of this is readable, but we talk about the alpha index to the Neoplasm table as well as the tabular list. Okay, so this is about following your good coding practices, your good coding process. Okay, this deals with current versus history, which we talked about. We will be doing more sessions on that. Okay. Classification, histologic behavior, anatomic site, cancer cell type, and acuity. Malignant neoplasm associated with a transplanted organ. And these are all, again, these are in your chapter specific instructions. Okay. Some information on leukemia, multiple myeloma, and plasma cell in remission versus history. And, you can go back and read this in the PDF. That does not necessarily require my narration or my input. And we can, if there's questions, we can always address that in a subsequent Neoplasm session. And then we have some information on grading systems. Okay. Because you're going to see this in the documentation. One thing I want to note, tumor grading is not the same as staging, okay? And you should understand that. And again, this goes back to in the beginning, I had said, understanding the many complex terms in neoplasms will make you a more effective coder in this chapter. Okay. And so just make sure you go through the PDF here and understand grading and staging and how it would impact your coding or not, or not incorporating something into your coding that shouldn't be incorporated. Okay. Some other terms in situ, localized, regional, distant, unknown. Anything that's not in situ is likely metastatic, where it's spread to other places. Okay. And you can get more information at cancer.gov. Okay. And so the information we've gone through so far is to help coders understand the common terminologies in regards to neoplasms, so that when we see the word adenoma, we know that it is not cancer. Therefore, we should not be coded as cancer. And some of the obstacles that you'll see in a chart. And we will be doing many more Neoplasm sessions. And so if you're watching this on demand and you have some question, please message us through the system. You can visit the website. Okay. And open a chat. Okay. Email us at info@aaomcp.com. well, you know, whatever. If you have an obstacle for not just neoplasms, any of the HCCs, but you can always submit your question and we can do a session that will answer your specific question. Okay, so that's today's session, and we thank you for being with us, and we hope that you'll be with us in future sessions. Again, if you have any scenarios, questions, etc., you know, please submit them so we can do a session to address your needs. Thank you, everybody.